The treatment of elderly patients with AML has been challenging for many decades, and the need for new therapies is an area of high unmet need. Venetoclax has been utilised in lymphoid malignancies, and Venetoclax targets a pro-survival molecule called BCL2. We know that BCL2 is overexpressed in acute myeloid leukemia, and a phase 1 study done in patients with relapsed and refractory disease demonstrated clinical responses in 19%. The current clinical trial explored whether the addition of low-dose ara-c, which has been used in older patients with AML for many years, could improve the clinical responses and duration of remissions in combination with Venetoclax. Historically, low-dose ara-c has clinical response rates of less than 20% and survival durations of less than 6 months. The phase 1 study introduced Venetoclax at a dose of 600 milligrams and 800 milligrams per day in combination with low-dose ara-c. 600 milligrams was determined to be the best tolerated dose, and this was taken into a phase 2 expansion in another 53 patients. So in total there were 61 patients treated with Venetoclax at a dose of 600 milligrams in combination with low-dose ara-c. The results demonstrated that this was a very synergistic clinical combination, with overall response rates of 61% recorded. 54% of patients achieved a complete remission or complete remission with incomplete bone marrow recovery. With a median follow-up of 8 months, the overall survival is currently sitting at 64%. And if we consider just the patients who achieved a complete remission or CRI, the overall survival currently for these patients is 80%. Further follow-up and expansion of patient numbers is required to gain greater clarity on the true duration of outcomes with this therapy, but certainly the outcomes have been extremely encouraging for an elderly population generally considered unlikely to benefit from intensive chemotherapy, and this will lead to a randomised trial in the future.
Has there been any subgroup analysis of these best responders?
Yes, there were a number of subgroup analyses performed on this patient population, which were 65 years and older, and generally considered unfit for intensive chemotherapy. When we analysed patients that were aged 75 years and older, clinical responses were 70%. In patients that had secondary AML, clinical responses were 52%. And even patients that had secondary AML and prior hypomethylating agent exposure had a response rate above 50%. Furthermore, patients with adverse karyotype had a clinical response rate of 47%, and there were very promising responses observed in patients with FLT3-ITD and also IDH mutation.
And how close do you think this might be to a practice-changing step forwards?
I think these initial clinical results are extremely encouraging, and change in practice will obviously require a randomised study to demonstrate improvements over survival with a conventional control arm. And I hope that these types of studies will be done over the coming year or two, and that a potential change in practice could be within a few years away.
Something to look forward to at the next ASH or EHA then?
Certainly we hope that we will have updated results on longer follow-up at next year's ASH, and that could really provide strong information regarding how durable these clinical responses are.